Can my canthopexy be reversed? I had canthopexy 1 year ago and am now considering reversal. Scleral was showing, but don't like small eyes now. I had cheek implants to get rid of negative vector, and now considering cheek lift to support bottom lids. 1. Any way I can open up edges of my eyes, but keep support in the bottom lid so no sclera shows? Is it possible to just loosen stitch instead of removing it? 2. Is reversal still an option, or is it possible that scar tissue developed, sealing eyes small? What are the options to open them if there is scar tissue?
Thank you for your question. The photo you submitted and the history of having had a canthopexy about a year ago, you asked several follow-up questions, mostly about the scleral show. And what are your options at this point? Well, it isn't easy for anyone to make full recommendations with the presence of just one photo, but looking at this photo, I can share with you some of the approaches that I have when looking at someone like yourself who comes to my practice concerned about scleral show. So, if the goal of canthopexy was to elevate the lower eyelids and to elevate the corners and create a shape that you like, then the lower eyelid position as it appears on your photo is several millimeters below the iris or the limbus. Okay, this is the area where typically, although there's a lot of genetic variation, but typically the lower eyelid meets the iris. And so getting that vertical height to the lower eyelid can be a challenge depending on several factors. Now, one approach is to provide support laterally and to try to elevate and maybe get a millimeter or two without doing anything else. But the other factors include the prominence of the eyes as well as the available skin to vertically move into the position that you desire. There are many people who genetically have prominent eyes, who have their lower eyelids relatively low, and that is basically a family trait. And then there are people who have had thyroid eye disease whose eyes are very prominent, and then there are people who have had, for example, a lot of people who come to us are people who've had surgery in the past and the lower eyelids are retracted down. So in our practice, we look at the position of the lower eyelid at basically three factors. One is the lateral support, which is the outer corner of the eyelid and where you had your canthopexy performed. The other aspects have to do with the front of the eyelid. We call that the anterior lamella. And then the other part is the posterior lamella. So there are three parts that are very important. And the posterior lamella probably has the most significant impact in terms of the physical vertical support. I refer to it as pillars that keep the eyelid in a particular position. Now that being said, you have to kind of figure out for yourself what the definition of a successful result would be. And for every 1 to 2 millimeters that you want to elevate to reduce the scleral show, it can involve procedures such as posterior lamellar graft. In our practice, we use a material called Enduragen, as well as possibly repositioning the outer corner of the eye or looking at or seeing if the laxity of the corner of the lower eyelid may require some tightening. Even when you do a canthopexy or canthoplasty procedure, the eyelid can stretch a little bit. You can get a little bit of elastic regression, and you may need some enhancement there. And then last is a factor of the anterior lamella. And for someone who's relatively young, that's a very a significant challenge, because basically looking at a relative amount of skin that has to be recruited to this area. Now that skin can be recruited via a skin graft, which is often not desirable, especially in a younger person who has not had surgery in this area in the past, or through an approach such as a mid-facelift. Now, it's been my experience that most mid-facelifts do not recruit as much long-term as they do short-term. We see many patients in our practice who have had mid-facelifts who the surgeon tried to vertically elevate the cheek, and it may have been somewhat successful in the beginning, but eventually a lot of these facelifts tend to descend, and that causes further descent of the lower eyelid. So in the absence of a physical examination, it is very hard to make those recommendations, but I think the purpose of my response to your question was to help you, inform you as to the anatomy that is involved in getting that vertical height. Very often plastic surgeons think of the lower eyelid from one perspective, which is the outer corner, and we've had patients who have been overcorrected where their corners of their eyelids were way too high in an attempt to reach that goal of elevating the lower eyelid. But there are, you should at least understand, there are three components. Again, there's the lateral component, there's the anterior or the front part of the eyelid, and then the posterior, which is the pillar or the support of the eyelid. It is very important that you communicate with the original surgeon about your concerns. And it is important that you also communicate what your desires are and see if this is something your surgeon is able to accomplish. If for any reason you don't feel that your surgeon is comfortable, your surgeon doesn't want to do anything else, then second opinions are always recommended to at least get educated and not to necessarily undermine the first surgeon, but at least to get the information you need to make an informed decision. So I wish you the best of luck. I hope that was helpful. Thank you for your question.